most guidelines, it says look for H. pylori, eradicate it if present, and otherwise start a PPI. And there is some hints of efficacy of this approach, but actually nausea is kind of a symptom out of the blue. It's not a core FD symptom, and we just heard that it's very often there, and especially in the PDS group where symptoms are meal-related. And the dogma has been that this is the group where prokinetics can help. This is a dogma that has driven a lot of the activities of motility societies in the past, and it has driven the development and usage of prokinetics, because it is thought that PDS is kind of a manifestation of disordered motility. And if nausea is occurring after the meal as well in this group, it might be part of this dysmotility effect. And then prokinetics might be a consideration. Now, prokinetics are a problematic class because they group a number of molecules. I have listed to the left here several of them, who have all in common that they are able to enhance gastric emptying, but they are heterogeneous in their pharmacological mode of action. Some of them affect visceral sensitivity in a positive or a negative way. All of them stimulate anthromotility, that has to do with their stimulation of gastric emptying, but they may also have opposite effects on fundic accommodation. And most important for this discussion on what does the nausea change, some of these prokinetics have anti-nauseant and anti-emetic properties. And this has to do with one specific pharmacological profile. This is the dopamine 2 antagonistic activity. This is well known for metoclopramide, for nonperidone, but both of these medications have been associated with side effects or risk or adverse events. Itopride, the dopamine 2 antagonist, which is also a cholinesterase inhibitor, available in some parts of the world, and levosulpiride, the dopamine 2 antagonist, which is also an antipsychotic, so it may cause some drowsiness.